Founder of the Deuk Spine Institute in Melbourne, Florida. We are performing cervical spine surgery today. We've already completed a very long and complex lumbar surgery that took most of the day. That patient's doing fantastic. He's in the recovery room waking up. And, yeah. How did that happen? All right, thank you. Yeah. Hold on. Time out. Let's get another, like, half sheet or something here. Right here, just to be safe. So, we finished the big back surgery, which if you go and look on YouTube, you'll see. And now we have the exact opposite type of surgery, which is a minimally invasive 4mm skin incision, endoscopic repair of a herniated disc rather than removing the disc and fusing like every other doctor does, or removing the disc and putting metal disc in, artificial disc. There will be no artificial disc, there will be no fusion, there will be no metal, no plastic, no biologics placed during the surgery. This is the most advanced surgery in the world for treating a herniated disc in the neck. Okay, why is the laser fiber here like this?
It's connected to the
okay, what about there? We're good?
Yeah, we're good.
All right, just want to make sure it's sterile. Okay, and our patient comes from Canada. He is a professional hockey player, and he has experienced pain in the neck, which shoots into his left arm, which over time has improved in terms of the pain, but he's still getting trouble with his balance and his coordination and sensation in the left arm as a result of a herniated disc, which we've identified on his MRI. The herniated disc is at the C5-6 level. We're good here. We're good. Just leave it there. Do you have a snap or anything? No? Here. You don't need this, right? So he traveled all the way from Canada here to Florida for the Deuk laser disc repair. All right. Are we relaxed?
Yes.
Blood pressure is good? You can bring it up a little if you want. So, hold on, I'm not ready yet. All right, now we got our x-ray, and I can see from the x-ray view, which is a side view, number 2, 3, 4, 5, 6, 7. Now, just to remind myself, we're doing the right side. Everyone's in agreement. We're on the right side. And we're doing number 5, 6. I could see the MRI. Do you have the MRI, Sean, you could share with our viewers?
Yes, I just saw it.
Beautiful. So the MRI shows a large herniation at C5-6 that's eccentric to the left, and it's causing severe compression of the lateral spinal cord at C5-6 and the C6 nerve root. So without further ado, we're going to get started. Just to orient you, the chin is here, the face is looking up, and this is the front of the neck, Adam's apple. And I'm going to be going just to the side of the Adam's apple, palpating the spine with my fingers as I am doing such. I'm touching the middle of the spine, actually, and because he's relaxed, I'm able to do so. Shot, and let's just see where we are. 2, 3, 4, 5, 6. I'm a little low. I can go a little bit higher, which I shall. Go. So still a little low. Could be a little bit higher. Are we okay? Shot. Is that Sean? Yes. 2, 3, 4, 5, 6. Got to move the light out.
You can turn out that one if you want.
Move that light out. You guys got to check that ahead of time. Lift it higher and move it over to the side, please. Can you guys see okay? That's good. Yeah, that's fine. Shot. Is that it? Okay, let's get an AP. Quick AP before my fingers fracture off. Quick shot. All right, looking good. We're a little far to the side. We'll come back just a little bit and shot. Lateral, that's good. So we're going to use the APN lateral x-ray views to locate the center of the spine, and basically I'm going to, come on, quick lateral. I'm going to advance this needle shot. That's good. 2, 3, 4, 5, 6. You all agree? 5, 6. Shot. That looks good. Shot. All right, let's get an AP quick. I don't want to move anything until I get my AP. Shot. Let's do a quick shot. It looks okay. It looks like we're a little bit off to Luis's side. So I'm going to bring it back, move it over, and go down again. Shot. That should be better. All right. Lateral quick. Shot. Nice. All right. I want to shot. I'm inside the disc. I could feel it. Shot. All right. So we got 2, 3, 4, 5, 6. Everybody agree? Now I need an AP. 2, 3, 4, 5, 6. So I'm in the disc number. Come on, guys. What is that? I'm inside the disc that I need to be in. I don't like, perfect. I'm in the dead center of the disc. All right, good. So let's just stay there for a moment. We're going to do our discogram. Now the discogram is done because we're not trying to do an evocative discogram like we do with lumbar or thoracic when the patient's awake. It's strange. There we go. We are doing a chromodiscogram, and that's different than a provocative or evocative discogram. Coker. In that I'm not eliciting a pain response. Shot. Yeah, look at that. That is so cool. Save that. Look at the dye going down to the left around his nerve root. So it shows you the tear on the left side and the dye coming, go to lateral while I'm talking, please. And it shows the dye shooting around the nerve root on the left. That is so cool because it's leaving the disc on both sides. He has a tear on both sides, but it's worse on the left, and you can see the dye just snaking around the nerve root there. All right, well, there you have it. Nice job. We are in the proper disc, the 5-6, and I'm going to place my guide wire now that I've done my discogram. And we've confirmed the tears and the herniation. We can see them on the x-ray. 2, 3, 4. Are you concerned? Yeah, I just want to make sure. There's nothing you're concerned about, right? Everybody's certain. 2, 3, 4, 5, 6. All right, I've got the guide wire in, so I'm going to remove shot. I'm going to remove the needle. We're going to do this entire surgery endoscopically. And this is, I am the only surgeon really in the States that does this endoscopically. It requires special equipment. Shot. That's the current shot. Oh, so that's, hold this for a second. That's the, I just don't like that being there. Let's see if we can do that. Shot. That's much better. All right, so there are very few surgeons in the world that know how to do endoscopic spine surgery, and there are 3 areas of the spine: cervical, thoracic, lumbar. I'm the only one in the United States doing cervical and doing thoracic endoscopic surgery. There are some doing lumbar. Lumbar means lower back. And then, of course, we are the only place where you can have the Deuk laser disc repair done, which is the surgery that cures back pain. Shot. I'm not ready yet. I raised the wheel. So I'm going to make my incision. I need help here seeing. Can you reflect the needle, this guide wire, slightly north? Just slightly. Huh? What are you thinking? Yeah. It's just challenging here to see. All right. That should be it. I hit a little vein under the skin. Not a big deal. There's nothing I could do about that. There's no way to avoid that shot. All right, as we go down with our dilator, I want to make sure the guide wire is not advancing. Shot. I want to bring my dilator through the tissues between the carotid sheath on the lateral to it and the shot trachea and esophagus medial to it. Are you pulsing?
Yes, sir.
Try to reduce the field. I mean, your field is way too wide. Why would you not have brought your collimator in a little bit so you don't radiate my hands? Shot. Even more. Shot. Shot. I may have to enlarge the skin incision just a little. Shot. All right, so we're now sitting on top of the spine. Okay, right in the middle, right where we want to be. Let's do one more shot real quick. Let's get an AP just to make sure, Coker. So we're using x-rays to navigate to where I want to be in the spine, which is the C5-6 disc herniation. That's perfect. We're right in the middle. You can see the spinous process right above the tip of the dilator. And of course below the dilator as well. So we're right in the middle at the anterior longitudinal ligament before I enter the disc. Okay? And we are pulsing. All right, perfect. So now I'm going to enter the C5-6 disc from the front. Okay, enter with the dilator. Shot. Perfect. And now I'm going to head towards the back of the disc, but I can remove the guide wire. Shot. Yes, it's perfect. Take it. We don't need the guide wire anymore. And remember, all this is being done with a 4mm incision. I want to get to the back of the disc where the herniation is. All right, you see the tip of that little black pencil there? That tip of the pencil is literally sitting on the herniation, right at the base of the herniation. Now I'm going to slide over that a tube. And we're going to use, can you see this tube, Sean?
Yes, we can.
I'm going to use this tube to do the entire surgery. This tube is 4mm wide. So the entire surgery will be done through this tube. There's no other surgeon in the world that does this. There were some surgeons in Korea that did it years ago, but they stopped doing it. And unfortunately, you need specialized equipment and training and supplies to be able to do this kind of surgery. So the reason I'm emphasizing that point is you're not going to see this done anywhere else. If you go to your surgeon where you live in Detroit or San Diego and you say, hey, I want endoscopic cervical disc surgery like I saw at Deuk Spine Institute, they're going to think that you literally came off a alien spaceship and that you're crazy. There's no such thing. Unfortunately, most surgeons don't even know this surgery exists. Mallet, I'm going to bring this forward a slight amount more. I really want it embedded right where I want it in that herniation. And here we go. We're bringing the tube down. And we're going to slide this tubular retractor over the dilator, through the soft tissues of the neck, past all the vital organs, to the front of the spine. And then I'm going to pass it through the disc from the front to the back without damaging the disc. All we're doing is we're spreading the jelly, okay? So we're using the dilator to literally spread the jelly apart. Imagine sticking this thing in a jar of strawberry jam and then taking it out. There's no damage to the jam at all. It just spread it open. So we're able to do the surgery atraumatic to the soft tissues because we're not opening the soft tissues in the neck. All right, here we go. So everybody agree for the last time we are at C5-6, right? And that is the proper level.
Yes, sir.
So we're going to the point of no return. So we're bringing the tube through the disc. Oh, shot. Okay. So now my dilator has moved backwards. I don't want that. I want to just advance it just a millimeter or two forward. Shot. Because, yeah, that's good. Because if my dilator slips back, then my tube is going to just do a biopsy. Shot. And I don't want a biopsy of the disc. I want to get to the herniation and take it out. Shot. So what makes this surgery so amazing is that we're able to leave the whole disc alone. The part of the disc that's not damaged, shot, that's not a problem for the patient. We're not taking that whole disc out in the front. Therefore, we don't need to, shot, we don't need to do a fusion. I think that's pretty good. So you can see the tube is now at the back of the disc at C5-6. The back of the disc is where the herniation starts. So the tube is literally right at the base of the herniation. And I'm going to start removing this herniation from the base, okay? Without taking the rest of the disc out. See that? That's pretty cool, huh? All right. Now, let's get this herniation out, and we'll be done with his surgery. Much better than that big open fusion we just did. We've lost a few drops of blood, and that's pretty much all the blood we're going to lose, just getting in there.
Yeah, please.
All right. Great. No, gentle with the laser fiber. I don't know what you're doing there, but I'm not sure I like it. What is this, a new IV tubing? It's a lot harder. It's a lot firmer. Look at this shit. I don't like this. Wait. Easy, you're moving this around too much. Okay? All right. I'm not so sure I like it. All right, where's my blue towel that goes here? Good. Where's my wrist? Can you all see this here, Sean? The neck and how we've accessed through a small incision?
We can.
All right. Good. Let's advance the laser to the end where I want it. And you're going to wrap my wrist? Go ahead. This is part of the water management system. Okay, we use a lot of what's called irrigation, and the irrigation tends to end up on my shoes, and I don't like that because it gives me cold, wet feet. Irrigation on, please. Got it? We're good? Thank you. Okay, here we go. Lights down. We are just inside the herniation right there. You see that? So I'm going to try to focus a little better. That's good. And then we're going to get started. Where's my pedal? We should be on 20.
We are on 20.
All right. Here we go. So I'm going to zap this herniation out of here. I need the light down a little bit. The intensity is too high. Let me see here. Huh?
Is it still too high?
No, we're good. Thank you. So I'm going to use the laser to free up the fragments of herniation. There's a piece right there. Let me grab that out. And after we've removed some of the herniation, you're going to start to see, oh, that's a good piece. Yeah, that's a good piece. You're going to start to see the end plates of the bones in the back. You'll see the epidural space. You might see the posterior longitudinal ligament. I think that's, and then you'll see the foramen, the neuroforamen on the left in a little bit. And then, of course, maybe, I doubt it, probably won't see the nerve root. We might see the spinal cord. Oh, another fragment of herniation right there. I may need the x-ray machine again in a little bit, just to see where the tip is. I don't think it's moving back too much, but it tends to want to move backwards sometimes. Did you get it?
Yes, sir.
I can't get any more. Let go. All right, so we've already used some grabbers, little micro grabbers, to really grab out a few of the fragments, and that makes this part easier. Okay. So once again, we're inside the herniation at the base. We got a lot of work to do here to get this right. It's a little more fuzzy than I want it. Is Jordan here?
Jordan is here, yes, sir.
All right. Just want to make sure. I might need you, Jordan, to take a quick picture in a few minutes, just to verify where we are. This is all part of that tear in the back of the disc that we so commonly see. There's another piece of herniation there. And the herniation fragments, they really want to come out of through the tube because they're under pressure. You know, when the herniation pushes out, it's under pressure. And let's just get a quick x-ray. Yeah, just get a quick x-ray. I just want to see where the tip of the tube is. If I need to re-advance it. Watch it behind you, Luis. So any questions from the audience at this point?
Yes, we do have a question coming in from YouTube. One of our viewers is wondering, is this surgery done anterior or posterior, and is it different from a foraminotomy?
Yeah, it's a great question. The surgery is done anterior. We're going through the front of the patient's neck. Go north a little bit. We're going through the front of the patient's neck. No, you're overexposed. Go north more, I think. Shot. All right, that looks pretty good. We're in the back of the disc still. All right, you can pull it out. It hasn't moved. So we are going through the front of the neck. This is an anterior approach, transdiscal. We're going through the normal disc, but we're leaving the normal disc alone. Every other spine surgeon in the world takes the disc out. Okay? This surgery could never be performed with a foraminotomy because we're not talking about a foraminal. I need the endoscope view back. We're not talking about a foraminal disc herniation. We're talking about a herniation that is anterior to the spinal cord. So think about that. There's the fibers of the posterior ligament right there. See the white fibers just below the laser? Yeah. So this patient's herniation is in front of the spinal cord. You can't reach that with a foraminotomy. Impossible. Foraminotomy is, in my opinion, a horrible surgery. I don't ever do it. I do it only when I do big open surgeries in the back of the neck, like fusion. But foraminotomy is just not a very good surgery with respect to the results. Okay? There are people doing them, doctors doing them. Yes, I agree. But in my opinion, it's not a good surgery. It destabilizes your spine. The doctor, to do a foraminotomy, the surgeon has to remove bone out of your foramen. Think about that. He's taking your bone out of your spine. The bone that was there and you're supposed to have that stabilizes your spine is being removed. And it's being removed right where the joint is, the facet joint. Okay? So a foraminotomy in the cervical spine requires that the facet joint be removed, part of it. Imagine if I said to you, I'll fix your knee, but I got to take half of the knee joint out. If I got to remove half of your bone in your knee, I mean, you know, it's obvious that that means we're going to destabilize your knee. It's never going to be the same again. It's going to be weaker, more prone to injury, more injury. By the way, this is the herniation I'm taking out. That's the posterior longitudinal ligament right there. And I don't think he has herniation behind it, but I'm going to have to look anyway to make sure. You can actually see pretty good, huh? Pretty amazing. That yellow thing over there behind the laser is the end plate of C6. And this over here is the end plate of C5. A little bit of cartilage there, and this is the herniation. It's amazing. We've been taking it out. This is all herniation right where the laser is. All that stuff there. So to me, this herniation is what we call obviously extradural. It's above the dura, but it's also superficial, closer to the disc relative to the posterior ligament. Okay, which is those fibers you're seeing, those thick white fibers. Those are posterior longitudinal ligament. I'm out in the foramen now. That's the foramen, right where we're zapping. That's out in the foramen on the patient's left, which is his symptomatic arm. Okay, we wanted to do a left foraminotomy. That's what we're doing. Okay, we're doing actually a foraminal decompression right now without removing bone. So I'm not taking any of this patient's bone out of his spine. I'm not weakening his spine. I'm not destabilizing his spine. I'm doing nothing of the sort. A foraminotomy is done through the back of the neck, and it is a procedure where the surgeon is going to remove part of your facet joint, and they are definitely going to weaken your spine. What's interesting is there's a little bit of blood in the, kind of in the back of the disc there, a little hemorrhage. Okay, not recent. It's either hemorrhage or granulation tissue. It's really hard to tell, but either way, it shouldn't be there, so I'm zapping it. Okay. Now I'm moving here. I'm moving more towards the middle of the disc. Here's some torn posterior annulus that we need to clean up a little bit. And I'm very careful not to let the scope go forward and go into the spinal cord, which is, I know what happened a few times in Korea. The Koreans are actually the first to do this procedure. Stand by. They're the ones who taught me, but I know that they had some complications. Of course, they haven't told people about it, but that's exactly what happened. And they actually paralyzed a few people, which I've never done in 16 years of doing the surgery. But that's what happens when you keep your patients awake during the surgery and they're flopping around on the table. There's a piece of herniation moving around. Let me grab that. They also use a different laser than I use when they use a laser. So just different techniques. They don't do the annular debridement that I do, since that's our discovery here at Deuk Spine. All right. Let's see what we got here. There we go. That is a piece of herniation right there that is huge. I'm trying to release it with the laser, and then I'm going to grab it with the pituitary. It's pretty big. I don't know if I can get around it. I was talking to my patient yesterday, and he's just so thankful that he has the opportunity to have this endoscopic laser surgery done. He was telling me about how he wants to get back home and hang out with his son. His son I know his children mean the world to him, and he hasn't been able to do much with them lately because he's been really incapacitated from this disc herniation, which is a huge herniation, just pushing on his spinal cord. And every time he goes out and does anything, he's putting himself at risk for becoming paralyzed. That's the problem with these herniations, you know, is that they're pushing on the spinal cord. This is all herniation right here. I'm sitting in it right now, inside the herniation, just in the foramen now. And you see the posterior ligament fibers right there. That's right where the nerve root's going to be, just underneath those. And I don't really want to mess with them. I just want to get the pressure off the nerves. That's my goal, and I'm doing that right here. That void that I've created now, folks, that whole void there is where the herniation was. Okay? You can see the laser fiber. It looks like a little piece of glass. That's your laser fiber. Okay? And you just have to be really careful working around the nerves here in the foramen. Again, more pieces of herniation just wanting to float up and out under the pressure of the irrigation we're using. Going back to the middle of the disc, where I know there's still some areas that need to be dealt with. You can see here. Wait. Yep. This is a torn annulus right there with scar tissue. See the white stuff? It's all, how do you explain it? I've taken this stuff out of herniated disc before with open surgery. You like scrape it and it's like tough crab meat. Here it's so easy with the laser. It just blasts it away. There's another piece coming out. Any questions from our audience?
Not currently.
All right. I do know that his physiotherapist in Canada is watching. Maybe she can shout out and say hi. I had the pleasure of meeting her before surgery. She was asking when the surgery was going to happen. So, hey, you got your physiotherapist watching. It's too bad you can't get some of the surgeons in Canada to watch. And you guys wouldn't have to come all the way to Florida. But that said, I really love treating you guys. Canadians are really my favorite, some of my favorite patients, to be honest with you. They're so appreciative of what we do for them here. They can't get this care in Canada, unfortunately. And we've had patients from other countries as well. They all are very appreciative of what we do for them. So it's nice.
We have a question.
Sure.
A viewer on YouTube is wondering, so what do you recommend if a person wants to learn about minimally invasive spine surgery?
I'm sorry, Sean, I really couldn't hear the question. Could you repeat it, please?
Yes, the viewer is wondering if they're a doctor who wants to learn minimally invasive spine surgery, what steps do you recommend?
Oh, so they're a doctor who wants to learn minimally invasive spine surgery. That's wonderful. Well, the first thing is you have to be a surgeon. So I don't know if you're a surgeon, but let's assume for the moment that you are a surgeon. You need to be a neurosurgeon or an orthopedic spine surgeon. Oh, look at that herniation. It came out of the epidural space. Beautiful. Doesn't want to come. I'll grab it. Okay, so now we know there is a subligamentous component to this herniation. It's deep to the posterior longitudinal ligament. And I'm going to have to open it to make sure I get it all. So either a neurosurgery or orthopedic spine surgery, which means in the United States do orthopedics and then do a fellowship in spine. I'd say maybe 10 more minutes max, doctor. And then you need to come and do a fellowship with me, because the honest to God's truth is there are very few real endoscopic, minimally invasive spine surgeons in the United States, but I am one of them. I do big surgeries and I do little surgeries, and I always try to do little surgeries when you can, because it's better for the patient. But that said, I don't only do little surgeries. If you watch my last surgery, you know what I'm talking about. Here we are in the middle of the spine, and we saw a big herniation come out of there. Okay? That was sitting right on his spinal cord. And here's another one. Wow. Well, it's unfortunate. So this thing did burst through his posterior ligament in the middle of the disc, basically. And now it's sitting on top of the spinal cord. So there's another piece coming out. This is all that giant herniation he has on his MRI. So we're getting it. The good news, we're getting it. But the bad news is I had to go through the posterior ligament to get it. Most of the time, there's another big piece. You see that? Incredible. Yep, come on now. You got to coax it out a little bit. I've got pepperoni pizza. Come on. Just kidding. You see that tear in the back of the annulus, and the herniations are now coming back through it? We call that a reverse herniation. And Deuk Spine Institute was the first to coin that in our paper that we published back in 2012, I believe, or 13, whichever one mentions that. Reverse herniation concept. Okay. I'm going to have to cut some more of these fibers. There's another herniation, reverse herniation, coming from right on top of the spinal cord, folks. Literally sitting on the spinal cord. And the only thing keeping it there are these fibers, these last few fibers of the posterior ligament, posterior longitudinal ligament. Oh, yeah, we're going to get a rupture. There's like a zit popping. It's about to come. Here it is. Uh-huh. Come on now. I know you want to get out of there. It's tethered down. It's so cool. There it is right there. See it? I'm not zapping because it's right on the spinal cord. But that's what needs to come out right there. That's the herniation sitting on the spinal cord. That's the end plate right there of C5 and the end plate of C6. So I'm going to try to grab it out by just using some little grabbers that are long and skinny that go down the tube, and I could feel it, and I'm trying to pull it out. It's kind of hard to get. I'm not really having any success. So what I can tell you with this herniation is there's two components. One is a subligamentous herniation, which is this thing right here, and a bunch of the other stuff that's already been coming out. Okay? And then there was also part of the herniation that was, subligamentous is the part that we already took out, and then this is the epidural component, the part that shot through the posterior longitudinal ligament into the epidural space, compressing the spinal cord. And I just want to be careful because we're literally on top of the spinal cord. So I'm going to try to blast this thing away, but I don't want to get carried away and have a problem for him. Man, it's a good size herniation there. I think 10 minutes I may have been a little too ambitious. This is just a giant herniation. All right, let's see what I can do. Oh, see that? Right there. I'm going to try to grab it out. I got some of it. Let's go look again. So removing herniations, by the way, in case you haven't noticed until now, is, oh, there's a big piece right there just sitting in the tube. We even got a big piece out too. I think that's a large part of it, to be honest with you. Taking herniations out, oh yeah, baby, is not one big piece that comes out, you're done. It's 99% of the time taking little pieces out. Okay, there we go. There we go. So, yeah. Pretty cool, huh? Sean, you have some more questions?
Not currently.
Huh?
None others currently.
There's another reverse herniation coming out. And another piece right there coming out. So you see I've already taken at least 15 pieces out. Okay? And there's still more. Well, things are going well. We're not having any problems. The herniation is much worse than I actually thought, even based on the MRI. The MRI paints a pretty good picture, but it's definitely more extensive than even I could tell based on the MRI. And that said, I think we're doing a pretty good job of getting it out. I'm going to rotate this around and approach it from the other. What was that?
What happened? Can you check it at least?
Did you lose the feed?
Yes, we lost the feed from the
so did
endoscope.
I think we unplugged it or something accidentally. There was a power glitch. Do we know why? All right.
Just be careful with the
Switch it.
cord, with the cord.
Switch the irrigation. It wants a white balance. Let's do that for it. I need some light or something though.
Lights on, please. Lights on, please.
Yeah.
We have a couple questions when you're ready.
Yep. Sure.
We have a viewer from Periscope who's wondering, when you remove the herniation and disc material, do you worry about destabilizing the spine?
Yeah, good question. When I remove the herniation, do I worry about destabilizing the spine? No. The herniation, the tear in the annulus, which occurred originally, which caused the herniation, that's the only thing that would destabilize the spine. So I'm not doing anything that would destabilize the spine. The white balance is pretty bad, huh? We need to re-white balance it. How do we do that? You know how to do it?
Turn off the light, please.
No. Do you know how to do it from the camera? Do you know how to? That's just the brightness. But how do I white
Turn
balance?
off the camera.
Is there a button that says white balance?
Turn off. Now you're gonna do it again.
All right, so no, removing the herniation does not destabilize the spine. If you take the disc out, the actual disc between the, if you take the disc out between the vertebral bodies, which is what every other spine surgeon does, then you will destabilize the spine, and that's why they do a fusion, and that's why they do artificial discs, because they've destabilized the disc by removing the whole disc just to get to the little piece in the back. But with the Deuk laser disc repair, we're not taking the disc out. We are just removing the herniation in the back. So there is no destabilizing the spine. All right, that is a little better. Yeah, that's better.
I usually do using the scope.
Hey, where's my laser?
Laser? I usually do it using the scope directly.
Huh?
I usually go through the scope, the white balance.
Yeah.
Yeah, that's good.
We have a couple more questions.
Sure.
A viewer on Facebook is wondering, is this a fairly new injury that we're looking at or something older?
Oh, it's a good question. So, from the looks of things, it looks relatively new.
I think the brightness is kind of
Yeah, the brightness is too high. Take the brightness down. Yeah, nice. This part right here that I'm working on, where it's very scarred up, is older. At least maybe a few years old. Okay. But the part that has the fluffy disc material, that stuff is newer. So this stuff here, look right here, see the gold color? That's calcium, calcification. That's an older injury. It's been around longer.
And another
That's
question.
a bone spur right there. So this is probably the old part of the injury, and then there's some newer areas as well. Yeah, another question?
Yes, we have another viewer on Facebook who's wondering, is what you're doing treating a bulging disc? And what
Yeah.
happens to the material when it's touched with the laser fiber?
So the laser is releasing energy onto this, and it's destroying the tissue. It's vaporizing it. Okay, it's annihilation, for lack of a better word. It's we call it vaporization. It basically injects the energy into the tissue, and it causes disruption of all the covalent bonds between the molecules. Basically, blowing it apart. Very powerful, very cool stuff. Very, very precise. So, I am treating the herniation. Yes, this is the bulging disc, the herniated disc, right here. And there's some more right there in the epidural space. All right. See that piece of herniation right there? It wants to come out so bad. But it's literally pushing on the spinal cord. There it is. Just pulled it out with the grabber. Amazing. So don't get the idea that all I use is a laser, because I don't. I'm hoping you're all able to see the grabber that I use as well. It's a standard surgical tool for neurosurgery. It's called a pituitary. There's the spinal cord down there. You see it? All right, we're almost done here. Oh yeah, come on, get out. Get out of there. These are like little demons. Little demons. No, don't you go hiding. I'm not going to let you hide in there. There, yeah, the last bit of the herniation. You can actually see the spinal cord below it. So, I just got to rock this little piece out of here. Come on, man. Get. Don't make me zap you completely. Sometimes these herniated fragments, they just don't know when they've lost. You know? I want to give you some attitude. There we go. Yeah. We have a cheer. All right, so just about done. Whew. This has been an adventure. Whew, yeah. Look at all that scarred dura right there. It's all scarred up from inflammation. That's where the herniation was sitting right there, folks. Pretty cool, huh? Yep. It's amazing. This is, again, a professional hockey player from Canada who started just to feel like, yeah, there's something wrong, you know? I'm not normal. I've got something going on. And had some neck pain and arm pain on the left side. Okay. And basically decided I'm going to go get checked out. So he did. And he was told that he needed surgery in Canada, but he needed a fusion. Well, he didn't want a fusion. Okay? He wanted something else done other than fusion. So here he is. He got his laser surgery done. And we're just about to finish in 2 minutes. This is the foramen once again. And we're pretty much done. I'm pretty happy with that. All right. Good. I'm going to give you all a chance to see what we did. So, watch out for that. Let's move the laser and the scope back. Is the scope off? Yeah? Okay. So let me just show everybody, and there's some herniation right here. Okay, like right there. Want to grab it? Let's show everybody what we're doing here. We got the rig here. We call it the endoscopic rig. Irrigation, light source, camera, endoscope, laser fiber, and then we even have suction on the tube here. And I go down to this little tube and this little hole to the back of the disc, and basically that's what we did to fix the herniation and repair it. Okay. Now, the problem is this is a difficult surgery to learn how to do, and if you're not trained properly, you'll hurt somebody badly. Fortunately, I learned good technique, and I've never had a complication in any of my endoscopic laser surgeries now 15 years. So 0 complications. We're done. You can see the incision right there. He's got a little vein bleeding. So we're just going to hold some pressure for a little bit. It's probably external jugular. Yeah, the good thing is with this surgery, you don't have really a potential space that we're creating, except for the track. So this is a athlete, so he's got a lot of circulation, obviously. The veins, usually if you go through a vein or you tear a vein in surgery, you just put pressure, usually for about 4 to 6 minutes, and then that's all it takes. I was going to show you the incision, but I want to hold pressure for a little bit until it clots off. Any more questions, Sean?
None currently.
All right, how's his blood pressure? Perfect. So this patient will spend about an hour here recovering, and then he gets to go to his hotel. And from his hotel, he's going to go back home on Wednesday after. I think he's actually staying a few extra days with his wife. But they're going to basically head out this week. Just get everything broken down. You have the bandage ready? Just wait a second. I want to make sure he's clotted off.
I need a 4x4, please. I think are over there in the table. Yeah.
Looks pretty good, but we're going to wait just another minute. So the external jugular vein, for those of you interested in doing the surgery, it sits just on the sternocleidomastoid medial border, just in front of the sternocleidomastoid. And the external jugular vein is, it feeds, it's a tributary to the internal jugular vein, but it drains the superficial tissues of the face and the upper neck. And basically in some patients it's non-existent, in other patients it's big. And obviously in an athlete who's played sports their whole life, it's going to be bigger because they just have a lot more circulation because of their activity. But it's a vein that in surgery we could sacrifice without hesitation. In other words, you don't need it. There's plenty of other veins that drain your neck and your face, but it's always nice to save it when you can. In this case, if I had to bet, I would say the external jugular was nicked or a branch of the external jugular. But the pressure you put, at least 15 millimeters of mercury pressure, allows that vein to to heal, basically. It basically clots itself, and then over time, it heals. So, in hospitals, we frequently put IVs in external jugulars or even in the internal jugular vein, the big vein, and if we do that, we just put pressure for a few minutes and then it stops bleeding. So, and it still wants to ooze a little. Was he on any anti-inflammatories? I don't think he was, right? Mm-hmm. Yeah. He's got big veins, yeah. I mean, you can see it's deoxygenated blood. It's dark. Is that for this? Yeah. So he's Canadian. Maybe they just take longer to clot off. How's our first patient doing? You want to call over and see how he's doing? Is he awake and out of bed yet? He was a little cold. Not just from the anesthesia, obviously. Huh?
I had the cold anesthesia.
Oh. Cold anesthesia day. But what makes patients shiver after general anesthesia?
I think it's a little bit
Good, good. Is it a central nervous system effect, or is it a, you know?
you get the shakes without being essentially cold.
Without being cold? So they still have the shakes. But do they say, I'm cold?
No, sometimes they're not really cold.
They just shake. Yeah, interesting.
And then you have the girl shakes.
Huh?
He's like a little Dutch boy.
Oh, I know. Yeah. Right? No, it's coming along, but I just want to make sure it's good. The neck is supple, and it's definitely not arterial. It's venous, but you know, and the way the anatomy is, the internal jugular vein is going to be a little more lateral than the carotid. The carotid is always more medial. So if you're going to get into any trouble in the carotid, it is at the skin. Yeah, we saw it right at the beginning when I cut through the skin. That's what I'm saying. It's the external. It's a branch of the external jugular, but it's just, it's a pain in the booty. It's almost there, almost done. It's just one drop there. I would hold it for another 2 more minutes. Check it out. And then we can put the bandage on, but give it another couple of minutes. So we're done with the surgery. Do we have any questions, Sean?
None remaining.
All right, ready to take off the field. Okay, I hope everybody enjoyed the surgery, and we'll have some testimonial videos for you probably later today or tomorrow. It's been a long day. Great job, everyone. Nice work.
Thank you.
Yeah,
Same to you. Great job.
thank you. Not bad for an old guy, huh? Haven't lost my touch yet. All right, Luis, we'll save these radiation gloves. Put them in the sink. These are nice. Yeah. Yeah, how much are they? $20 a pair, $40 a pair, 50? I believe it. Well, who said medicine's cheap? All right.